options are more limited than a KRAS wild type or a RAS wild type patient, but we still have at least 3, perhaps now 4 lines of therapy for such a patient. We start with FOLFOX, obviously, went to FOLFIRI-BEV in the second line, and then moving to regorafenib in the third line, and the fourth line would be a drug that's going to be recently that is going to be approved, hopefully, in the near future, TAS-102. And so in this situation, we may end up with 4 lines of therapy that would maximize the likelihood of survival. This continuum of care, I think, although we do have very effective therapies across lines of therapy, it's actually that continuum, sequencing these multiple lines of therapy, has moved the needle of survival from, in the old days, not so old, but they seem like they're old days, from 1 year to anywhere between 2 to 3 years at the median. So a huge shift, and we continue to improve on that. So you go with the continuum of care. Since this patient started with FOLFOX, the second line would be FOLFIRI, bevacizumab, and then the third line would be regorafenib. These are the approved agents and regimens at this point of time. And then TAS-102, which will likely be approved in the very near future, will become an option after failure of regorafenib for this particular patient. So right there we have 4 lines of therapy that would be lined up for this patient.